So a lot of you saw my last video about someone who was declared brain dead too soon and they tried to procure organs and then she ended up making a full recovery. And it kind of made an impact that I didn't expect and didn't want. A lot of you were scared now and talking about how you're removing yourself from the organ donation list or that you're glad you did. And that's something I want to clarify right now. I want to talk to you about how strict the criteria is and how it's one of the strictest calls in medicine to make, and how every physician and transplant surgeon I have ever worked with wants nothing more than to treat the patient in front of them now and not to harm another patient to help someone else. So first, let's define what brain death is. Brain death in the United States is equivocal to total and normal death. It's irreversible, irrevocable, unrecoverable. This means your brain has no more function, including your brain stem, and your body would be totally 100% reliant on medical equipment to keep you alive. Criteria for brain death require certain clinical conditions to exist, which I'll discuss in detail now. Number one, you need clinical or neuroimaging evidence of brain death, of a catastrophe or an injury causing damage to the brain. Two, exclusion of confounding or complicating medical conditions that are going to confuse the diagnosis, such as severe electrolyte abnormalities. Three, exclusion of drug poisonings, overdose, or sedation medications that would also confuse the diagnosis in clinical exam. That means this patient has to be totally off sedation and demonstrate no brain function or activity. Three, they have to be normothermic. They have to be a normal temperature. They can't be hypothermic because that confuses the rest of the clinical exam to determine brain death. Their systolic blood pressure has to be greater than 100, which can be achieved with medications. Let's get into the specific neurological exam. One, they have to be in a coma. That means they have to be in a state that demonstrates no cerebral activity or brainstem activity. To evaluate this, we test for response to pain. So they apply pain somewhere usually on the face to see if the patient responds. Non-response to pain is suggestive of lack of cerebral activity. Absence of a pupillary light reflex. The eye should typically be mid-position with no reflex to light sensation. Absent corneal reflex, you should be able to touch the eye and the patient doesn't move or respond, blink, twitch, or anything. An absent oculocephalic reflex, which means whenever you move the head, the eyes, as you can see here, my eyes are staying midline. They're making contact with you. That's a normal reflex. The eyes should move with the head. If the eyes are moving with the head, that's an absent reflex, which indicates lack of cerebral activity. And they have to demonstrate lack of a gag reflex, lack of a cough, lack of a jaw jerk reflex, and they have to pass the apnea test, which I'll talk about now. The apnea test is essentially taking the patient, disconnecting them from the ventilator, waiting upwards of 10 minutes, checking their CO2 levels to make sure they reached a pre-specified level, which is around 60. And if there is no signs of them breathing, they have an apnea test that is compatible with brain death. And something that's not as universal though is an observational period. For adults, the minimum observational period recommended is usually 6 hours, sometimes up to 24 or 48 hours, just to make sure that we didn't miss anything and we redo the test again at another time. Most states, a physician is required to conduct this brain death test and certify someone as being brain dead. In many places, it requires 2 physicians to agree that the test was conducted correctly and that someone is brain dead. There are other extra tests that you can do, such as cerebral angiography, transcranial Dopplers, and other tests to see if there is cerebral activity. Those aren't always done. They're not necessarily needed. There are 4 common cases where someone could have these 4 diagnoses and be misdiagnosed with brain death. And that's going to be 1, locked-in syndrome. That's essentially where you are paralyzed 100%, but you're still fully aware, which is a terrible and tragic thing to have. 2, severe hypothermia, which we talked about. 3, drug intoxication or drug poisonings. And then 4, other neuromuscular paralysis diseases like Guillain-Barré syndrome. It's so important to adhere to this strict criteria and to potentially have that waiting time. That's why it's also important that we separate the organ procurement team from the clinical treatment team that's taking care of the patient so that there is no external pressure. And everyone that I've ever worked with, they're pretty good at separating that. When I was dealing with my brother who was in the ICU and who was declared brain dead, we had 0 pressure from the organ procurement team. Hope this really gives you guys some reassurance that almost always the organ procurement and donation process is very well protected, and there's a very strict criteria, and organ donation saves lives. One organ donor can save up to 8 lives, which is amazing. So I really encourage you guys to become organ donors if you're not already. I'm an organ donor and my family members are organ donors.